Hello and welcome to another installment of the McKnights One On One interview series. I'm McKnight's long-term care news executive editor, Jim Berklan, and today we have a special edition of this popular feature. We'll be talking with one of the most enterprising long-term care provider minds out there about one of the hottest topics in long-term care today, value-based care. This is where you're going to learn great ways to improve those hospital and health system relations to boost referrals, census, and ultimately revenues. And you'll hear about it from a leader who knows how things work from both the administrative and clinical side of things. With me today is Dr. Scott Rifkin, Executive Chairman of Real Time Medical Systems. A renowned entrepreneur and innovator in healthcare, Dr. Rifkin has more than 30 years of experience as a physician and operator of nursing facilities. He's also the owner and operator of Mid-Atlantic Healthcare. That's where he's led a massive improvement of care delivery and clinical outcomes to residents of long-term care facilities throughout Maryland and Pennsylvania. Under his direction, Mid-Atlantic Healthcare's 21 skilled nursing centers have become a national leader in successfully developing risk-based care models. So, Dr. Rifkin, first of all, welcome. And if you don't mind, let's jump right in. What do you think is the future of payment systems in nursing facilities?
Jim, thanks for having me on today. The payment system is clearly changing, and you got to start with why it's changing. The old system really doesn't work. It incentivizes things that we shouldn't be that proud of. Pushing up length of stay, having people go to the hospital, come back as Medicare patients. And it hasn't been good for the industry. It hasn't created good reputations for us as running and operating nursing centers. It hasn't always done the best thing for the care for patients. I'm the biggest critic out there of CMS, but I will tell you they finally seem to have it right. When it comes to the concepts of how they pay for nursing care, the concept of value-based care makes tremendous sense. It does already incentivize the things we actually want to incentivize. Good outcomes, good care, keeping people healthy, keeping them out of the hospital. That's a train running down a track at a 90-degree angle. I mean, it is not going to stop. The folks at CMS have made it very clear that before the end of the decade, they want every single nursing home patient in some form of value-based care. And whether an operator is wedded and loves the old system because they figured out I was involved in that system too when I had the facilities. The idea of having a longer length of stay sounded like a great thing. In the new world, it's how quickly and how safely can we send somebody home, and how well can we take care of them so they don't end up in the hospital. That's the future for how the various reimbursement systems are going to be set up for nursing homes. And some of these value-based care programs come right out of CMS, and some of them are equivalent coming out of commercial insurers and the such. So we'll talk more about those as Jim poses, as you pose several questions.
That's right. And so let's delve into that a little bit. Why is it important for nursing facilities to begin adopting a value-based care mindset? You talked a little bit about it, but what benefits will they see?
So it's interesting. We hear a lot about how we get underpaid in the industry, and that's true, and how we can't get enough staffing, and that's true, and how little Washington really understands our staffing and financial issues, and that's certainly true. But what value-based care does is it opens up a whole new revenue stream for us. It really does. If we can share in the savings created by reducing hospitalizations and keeping people healthier, that's all new revenue, because that's money that today is being spent at the hospital. And many of these value-based care programs open up that new revenue stream to what we do, which really addresses some of the issues with finances and even staffing that we've had up till now. There's no question that there is savings if we keep people out of the hospital. There've been a bunch of studies, and I'm hardly an academic, but there have been lots of studies. And the studies show that 50 to 70% of the admissions from a nursing home back to the hospital are avoidable. They're avoidable. And even in practice, we see that. The institutional special needs plans that we'll talk about more that are out there are seeing a 40, 50, 60% reduction in hospitalizations By using nurse practitioners, a fairly expensive way to go, but by using nurse practitioners and data mining like real time, and it really is possible. There was a study done by Berkeley Research Group not long ago for us, not a study, but a little calculation done by Berkeley Research Group, big consulting group. And we asked a simple question. If you reduced hospitalizations by 50%, now that's the short stay patients, the long stay patients, and if you reduced it that 50%, how much savings is there on a federal level? $14 billion. $14 billion. What if we can share in 10% of that, or 15% of that, or 20% of that? That changes the economics of nursing centers. So, these programs are coming, and they're a huge opportunity as long as we can change the way we think about how we provide care in the nursing homes, because the old way is not going to work.
All right, now let's take it a step further. Can you describe the various types of value-based care payment models available to nursing homes?
Sure. You got to break that down into really two groups. You got to break it down into programs for short stay patients, whatever we see as our Medicare patients today, and programs for the long-term care patients. In many ways, the long-term care patients, which have been the sort of the stepchild, we always see it, well, we need more Medicare, and that's how we're going to make a living in the nursing homes. And I don't think that'll particularly change, but there are programs just for those patients, and then we'll talk about the long-term care patients. Start with the short stay, and then we'll go to the long stay. The short stay patients are going to be dominated by insurers, by ACOs, by folks who have big community populations, whether it's ACOs or a hospital-based program or an insurer directly or United or anybody else. And they're going to always see nursing homes as a bit of a commodity. Where can I send the patient that they're least likely to go to the hospital? They're going to go home the soonest. They're going to have the best outcome. They're going to have the highest satisfaction. There's huge opportunities there. If you're willing to go to an insurer, and we did this about 8-10 years ago, before anybody was using the term value-based care, we went to Cigna, and I had a quarter of all the beds in the city of Philadelphia. I had 1,200 beds. We went to Cigna, and we said, your length of stay in our nursing homes, and throughout the city, they were open about their numbers, where the typical length of stay was 23 days. We went to them and said, give us a case rate, pay us for 15 days, but let us manage the patients. And we did that. We hired our own case managers. We didn't work with the big care management company. We got them that Cigna was using. We got them to withdraw that. We did our own care management, our own discharge planning, our own social work efforts, everything we needed to do. We dropped our length, so they agreed to pay us for 15 days at the full Medicare rate. Okay, so what's that? $550, $600, whatever it was. Our actual length of stay was 10.8 days. We didn't need to keep people 23 days. We knew inherently you don't need to keep people 23 days. We were as good as anybody at having that long length of stay. But the actual length of stay was 10.8 days. The return to hospital rate was lower. From the nursing home was definitely lower. From the community when we sent them home was about the same as it was when it was 23 days. We had dropped our readmission rates on short stay patients from around 22% down to 8 to 10%. So all in all, there was a huge savings for the insurer. They were paying us for 15 days when they used to pay for 23. And we were thrilled to get paid for 15 days because we only took care of the patient for 10.8 days. That's the concept of value-based care. Keep them healthier, keep them out of the hospital, make sure they're safe when they go home, and share in the savings. So there are opportunities in the short stay, not as much as long-term care. We'll talk about long-term in a second. But there are opportunities if you're creative with your community risk takers, the ACOs, the insurers, that you can turn that into a value-based care concept. It's either that or you're going to be a commodity, where you're getting negotiated on rates against somebody else. And there's been a lot of that, and I hear it every day, and owners complain about it. But the only answer is you can't beat the economic forces that are creating this. The only way to solve that problem is to take the lead and take the risk and become a value-based provider, not a group that just optimizes how many days it gets paid for. So that's the short stay, Jim. Do you want me to jump into the long-term care side of that?
Let's take a look at both if we can.
Okay. So the long-term care population is inherently different. Very few of those patients are in any value-based care program. You have a few ISNP patients, I don't know, 100,000 out of a million and a half or whatever it is, millions of folks that now live in nursing homes. You have the REACH program that just got started. Those are really the two big programs, and will continue to be the two big programs. But there's still 90% of those patients aren't in any program, and they will be. And there'll be new initials that come out. You've got REACH, which is an acronym. You've got ISNP, again, Institutional Special Needs Plans under the Advantage Plan law. The folks at CMS are, they got a can of vegetable soup that they're picking letters from every day. So there'll be new programs. The ISNP program is an insurance plan. It's an Advantage insurance plan. And there are groups like Optum and the group that I'm involved with, which is Provider Partners Health Plan, and there's others out there. And they all kind of do the same thing. They take full responsibility on the cost of care. They get paid as an insurer. They have to get an insurance license. They have to get a network put together that the insurance commissioner approves. They got to go through a long CMS process, and it's fairly expensive to run. And the way they make it work is many of the programs have a nurse practitioner that comes into the nursing home. We added the data mining we do with real-time medical, and we drop admissions 50, 60% in that program. Our medical loss ratios are running in the 40s. We then share the savings two ways. We spend some of the savings on nurse practitioners. So it's sort of a circular thing. The more you save, the more you can have nurse practitioners. The more you save, but keep people healthier. And then the rest gets shared with the facility as the insurer pays a care management bonus to the nursing homes. And the idea is to reward the facilities for taking good care of folks, keeping them healthy, and giving up some of the fee-for-service concept that they're used to. They're not going to be billing for fee-for-service days and skilled days and all that. They're going to help you keep people out of the hospital. They're probably not going to do, they're only going to do therapy that's actually required, which hasn't always been the case. So that's one way of doing it. That has not gotten huge acceptance. It is a great program for the right operator. If an operator has done well with admission, they've got a low readmission rate, they've got a strong DON, they've got a strong administrator, they're already focused on really the good side of the equation of value-based care. They can do really well in that program and make way more money than they ever did with fee-for-service. But it's not the right program for every operator. It's just not. And it scares that change of how you do business and how you focus your revenue efforts is scary to a lot of operators. So it's great we have some great partners in Texas and Illinois and Maryland and Pennsylvania and Missouri. And I think I might have missed one. And we have 2 new ISNPs going live in the next year or two. And they're great partners to have. We've never lost a partner, which is really something we're proud of. But in the 8 years or 10 years we've been doing this. But there's also a new program that was just created recently. The CMS took the direct contracting program and renamed it REACH. And it really is an ACO program where you don't have to be an insurer. So the operating group doesn't have to get an insurance license, doesn't have to have huge, big reserves, doesn't have to have a network they maintain. It's a much lower cost program to run. And because the sponsoring group is not the insurer, CMS is still paying the bills. The operator really doesn't give up what they've been doing. They haven't changed payers. They still bill Medicare for what they were billing Medicare before. Okay. What they do want to do is partner with the sponsoring group to reduce hospitalizations. Purely that issue. Remember, we said there's $14 billion to be saved by reducing hospitalizations and reducing length of stay a bit on the short stay side. That $14 billion includes short stay and long stay patients. But 6 or 7 or 8 million of that is going to be the long-term care patients. And all you've got to do to make that program work, where an ISNP needs about a 50%, 55% or less cost of care on that, it's called a medical loss ratio. on each dollar of health, healthcare dollar attributed by CMS. A REACH program does well at 75 or 80 cents spent on healthcare. And so what you want to do as the partner for we have a company that does REACH programs in nursing homes. And as far as I know, we're the only one doing REACH programs in nursing. Well, that's true. There's one other that's doing it for their own docs. But generally, these programs are in the community. We focus on the nursing home population. What we want to do is use our ability with our data mining software real time to help the nursing facility avoid the hospitalizations that used to get them in regulatory trouble. That 10, 20, 30% of admissions that put them at risk. Mrs. Jones falls down. She doesn't fall down, and when she falls down, you get a deficiency. But you don't get the deficiency because Mrs. Jones fell. You get a deficiency because Mrs. Jones fell, and yesterday or the day before, somebody wrote in the chart that she wasn't eating and drinking. And somebody else wrote in the chart that Mrs. Jones was kind of dizzy this morning when she got up. And then she falls, and a surveyor then looks at it and says, that's a G-level deficiency. Using data mining principles, asking the right questions of our data. We have lots of people that work in nursing homes. They're well-meaning, they're well-intentioned, they're overworked, sometimes undereducated. They have very busy lives and difficult lives, some particularly in the nursing aid side. And we expect them to recognize, put A and B and C together a lot. They often don't. Nobody notices the dizziness and the low eating and putting it all together. The very simple thing to do, it's not rocket science, is go into the nursing home medical record, ask a lot of questions. What patient hasn't had a bowel movement in 72 hours? Well, if I give that patient some Colace, I may avoid a sepsis admission. Or which patient has a history of heart failure and is gaining weight? Well, if I treat that patient with 50 cents worth of Lasix, I probably avoid an ICU admission 3 days from now. So you can use data mining to prevent the admissions. And what we've done with that software platform, and we do it all over the country now. I think we're in 1,800 facilities already up and running, another 500 or 600 in implementation. And we're dropping admissions 30 to 50%. So you plug that into the value-based program that's the REACH program that only needs a 10 or 15% drop in admissions to work. And that becomes a really good program. And we actually think the REACH program is going to be the biggest grower of these value-based programs into the nursing homes. It's easier in, it's easier out. The license we have and other folks have covers all 50 states. And it's just so much easier to do. Where an iSNP can take 2 years to set up, the REACH program, you can go live in 60 days, 90 days. So it's an easier program, and we think that's where we're going to be. There'll be iSNP organizations, there'll be REACH organizations, but if you got to pick one, I think more people will pick REACH than iSNP only because it's easier.
Well, some excellent perspective on that. I don't know that I've ever seen or heard it spelled quite that way. And, that's of great value because, as you said, there's going to be a lot of alphabet soup and a lot of changes coming ahead, but the boulder's rolling, as it's been described to me. It's not going back. So I'd want to ask you too, though, as you're aware, nursing facilities have been facing really mounting regulations and immense staffing challenges. We all know that. What can they do to successfully shift toward value-based care payment models, given all of these challenges?
Sure. And let me throw a little more piece into that, Jim. There are lots of operators that have had us do the data mine, not because there's so much in value-based care, but because the folks sending them patients are saying, we're in value-based care. We don't want so many admissions to the hospital. You need to be better at preventing hospitalizations if you want our ACO, our hospital, our insurer to send you patients, okay? So when the concerns are on staffing and budget and all those issues in the nursing home. Value-based care can help that in a couple of ways. One is, look, if you can start earning dollars from the savings on the hospital side, which we've never been able to before, that allows extra dollars to hire more staff. You could argue that there's no staff out there, and that's kind of true, but we compete with Walmart and Burger King and all those $13 to $17 an hour employers for staff in our nursing homes at the nursing aid level. If you're finding more dollars of revenue, you can afford to pay people more, and you can get the staff in the door that you need to get in the door. On the regulatory side, the things you do to prevent hospitalizations, whether it's nurse practitioners or data mining with real time or any of the other things you can do, they all prevent regulatory trouble as a side benefit of lowering hospitalizations. So if Mrs. Jones never falls and breaks her hip because we picked up that she wasn't eating and whatever the issue was and we addressed it, it's not enough to just pick it up. You've got to have a system where you actually use that data and address it. So you have to have a program built around it. But if we do those things and reduce hospitalizations, we'll make more money on the value-based care side. We'll also reduce any of our regulatory risk. And when we started doing this in our facilities in Maryland and Pennsylvania, we dropped our regulatory burden by 75, 80%. It makes a big difference. And I got to tell you, there's nothing worse than when a surveyor taps you on the shoulder and starts a sentence with, "Did you know?" It never goes well. And what the data mining does is so you know these things.
You know ahead of time, and knowledge is power.
Well, when
knowledge
you can still
is power,
respond,
right?
right. If you notice that Mrs. Jones isn't eating and drinking, and you address it, you get the dietitian in, you make sure somebody's feeding her, and she still falls and breaks her hip, you don't get a G deficiency. I mean, the goal is that she never fall, but some people are still going to fall. But if the surveyors see that you picked up those issues and addressed them, they have no grounds to give you a high level deficiency.
Sure. Now, as we wind down through this discussion a little bit here, can you tell us, how does real-time's interventional analytics solution differ from data in the electronic health record or other data analytics solutions on the market?
We started that company really never intended to create a company. It was an in-house project. It was, how do we take better care of people? I'm tired of being surprised by things I didn't know. I'm tired of regulatory problems for things I didn't know. And we basically sat around a table, about 10 of us, and came up with a couple hundred questions. But then the real problem is, how do you get people to use that information? I can data mine all day, and every EMR can do it. I can ask all those questions. I can write queries myself. I can ask the EMR company to build queries, do all that kind of stuff. But if you don't make it easy for folks, if you don't make it simple, if you don't make it user-friendly, if you don't make it intuitive, nurses are busy, staff is busy. They just won't do it. If you ask for double data entry, they won't do it. Okay? And there have been software packages that do that over time. So I had a chief of nursing who came up to me and said very bluntly, she goes, "Scott, this is a great idea. And if you create 1 minute of extra work for my nurses, I'm going to kill you." And I'm not sure she was kidding. To this day, I think it was a real threat. So,
you don't want to test it. You don't want to find out, right?
I didn't want to find out. So we built it with the concept that we'll use whatever data's there. Now, people can argue that, well, that data is not so great in the nursing home anymore. A, I'd argue it's better than you think it is. But B, the enemy of the good is the perfect. If I can prevent 60 or 70% of admissions where before I wasn't preventing any of them, I'm a pretty happy camper at that point. So all we do is we search the data that the staff's already putting in. As soon as they know that you're actually asking about it, you go to a nursing aide and say, the data shows that Mrs. Jones didn't have a bowel movement for 3 days. And the nursing aide can say one of two things. Oh, she had one yesterday. Or, you know what? I guess she didn't have one. And if she had one yesterday, and you say, well, why didn't you document that? Guess what? It gets documented after that. So the documentation gets better when people know you're actually looking at the data. And if you just take that data and use it to prevent admissions, what we do is we ask these 300 queries. They're pretty simple and some complex questions. And then we push that information to the charge nurse, the DON, the administrator. We even have, for some of our clients, a call center with nurses that look at it every day. We work for a couple of the big insurers on the value-based side, where they have community patients going to nursing homes. And we look at that data and we call the DON or the charge nurse. We say, are you aware that Mrs. Jones, whatever, and DONs really want to know what's going on with their patients. They're not resistant to this. They're thrilled that somebody told them stuff that their own team didn't have the time or the energy or the access to pick up. And you see in those facilities 40, 50% drops in admissions. We do work with a big ACO in Southern Pennsylvania. 15 nursing homes, 600-bed hospital. They dominate their area. They've gone from 18% readmissions to 5 to 7% readmissions from their ACO population of their participating nursing homes. And it's, some of our facilities do this work themselves, where they get the push alerts, and others work with our call center. But they all get, if they do this, pretty good results. And you make it simple. If you make it hard, they're not going to do it.
That's pretty true with most any job, but you know what? People are so detail oriented. We know in this sector, it's easy to lose track, I imagine, too. So now, here's maybe your toughest question I'm going to give you, because I know there's a lot of examples, but can you give us a few? Can you provide some examples of how real-time has successfully helped nursing facilities succeed in value-based care payment models?
Yeah. So the one I mentioned a minute ago I don't want to say the institution, but in Southern Pennsylvania, big ACO, is actually the subject of a clinical study being finished by two of the big hospital centers on the East Coast. And they're going to publish that data in a major journal in the very near future. If I get if anybody wants some background on that, I can give it to them. But if I say too much about it, the journals get very edgy and they won't publish.
And don't worry, because I'm sure McKnights will be reporting on it as soon as it comes out.
Yeah, so we're thrilled if they would. I just want to be a little careful. But we have lots of examples like that. We work with ACOs, we work with insurers, we work with hospital systems that care. So we work with physician groups that just want to get their numbers better so they can compete better in their marketplace. So it happens every day. I mean, what I always say to our team, and it's fun to be able to say, is that you get up every morning and go to work doing something that really is nice, because we've proven, even in academic, everybody can say, I got a 6% reduction of decubitus ulcers. It's generally BS and the variation around the mean. We have academic studies showing 30, 40, 50% reductions. And the worst program we have is like 25, 30%. So and we're happy to share that with anybody who's interested. But it really does work. Now, it still has to be involvement by the facility. The leadership has to hear from, the leadership has to send the message. And the message is, this matters to us as an organization, because we've got to get ready for value-based care. The question were, how do we get ready for this train coming down the track? Start by just improving your outcomes. Start by reducing admissions, reducing length of stay where you can, keep people healthier and happier and out of the hospital. And in those programs, you'll end up in those programs, but start there, as opposed to taking on value-based care and then trying to figure out how to not lose money.
Outstanding. Now, as we close up today, any other words you'd like for the viewers here to really capsulize and maybe re-emphasize the few simple things, as you say, keep it simple, that they should keep in mind?
Yeah, look, we're always happy to talk about this topic and proselytize. And I do 20 conferences a year where I speak. And it's really always on this topic of, how do you create good care in your organization so that you'll succeed in the value-based care that's coming, whether you like it or not. There really isn't another option. And I've seen a change in attitude, actually. I was just at a conference in Phoenix. They did a great job. And I got approached by more operators than I ever have before, because they're starting to see that it's happening. When it was 10 years away, it was sort of theoretical. Now we're 6.5 years away, or whatever it's going to be. And there's even talk in Washington of speeding up that time frame. So I think the message is, get your organizations ready, start dipping your toe in the water with some of these. The REACH program, I think, is a really neat program to dip your toe in the water without taking any real risk, because those operators are typically holding all the risk. And iSNP is an interesting program for the right kind of organization. So I'd leave it at that. Anybody wants to call me or talk to me about it, I'm always available, and I'm easy to find.
That you are, and we appreciate that. Well, we want to thank you very much, Dr. Rifkin, for sharing some outstanding insights with us on this topic, because it is going to become increasingly important as we wade into the months and years ahead. This is made for another excellent installment in our McKnights interview series. We also want to thank you, our viewers, for tuning in. You've been a part of a great event. We look forward to seeing you next time. For McKnights, this is Jim Berklan, wishing you good health and outstanding days ahead.